Okay, so I'm Ken Lichtenstein. I'm the Director of HIV Services at Eisenhower. And Hi, Ken. Good, thank you so much. So what we're going to do, we're all sort of limited for time, so I'm going to be as quick as I can here and just let you know what we're doing, and then Ann Stapleton will finish up with this part that we do. So one of the studies that we've been involved with is the REPRIEVE study. REPRIEVE study is the randomized trial to prevent vascular events in HIV, as you can see. What this study is doing is it's looking at people who do not qualify to go on statins because they're too healthy, but because HIV-infected folks are more likely to have cardiovascular events than people who are not HIV positive of the same age. The idea is to see whether statins should be started earlier. And so the idea was to have a placebo group, which would actually be standard of care, and then add a statin to the other group, and to look to see if it would reduce major cardiovascular events, any cardiovascular associated issues, whether it would lower LDL and to levels that were less likely to reduce cardiovascular events. The other interesting thing is to look at whether it would reduce other comorbidities that we see in HIV, liver, kidney, and some malignancies because of the anti-inflammatory effect of statins. And then obviously it was to look at whether it was safe to give and that sort of thing. There are no results right now because the study is ongoing. It is currently closed to enrollment. It may open for enrollment later, but right now it's closed to enrollment. The next study I wanted to talk to you about is the Atlas 2M study. At the retrovirus meeting this month, they presented Atlas, which was the study just before this one that we participated in, which was looking at cabotegravir, which is an integrase inhibitor, investigational, and rilpivirine, which is in Juluca, Edurant, Complera, and Odefsey, so that's been around, but it's administered intramuscularly. And that particular study looked at intramuscular injections once a month compared to standard of care, and the 48-week data showed that it was, in the jargon of research, non-inferior, which means it was not better, not worse. It was close to equivalent. That's how they phrase it. At any rate, based on that, this particular study, the Atlas 2M study, is now comparing the 4-week injections to now 8-week injections, which means that every other month injections, or 6 times a year getting the injections, no oral medications. And so that's ongoing and fully enrolled as well. And it basically tells you what we were doing. The last thing I'm going to talk about is the anchor study, which we are doing in cooperation with DAP. So I want you to be aware that we are cooperating. And this particular, and there's yay. Our anoscopist over there, who is going to be looking at everybody's back. At any rate, the idea behind this is that the reason this is going on is that currently there is no standard way to manage human papillomavirus, which is the cause of anal dysplasia and anal cancer. And so the idea was to look at the model that was done with cervical pap smears, and that's what this is showing, because once they did that, there was a 75% reduction in cancer in women because of pap smears. And so what they're doing is looking at what about the HIV population. Here's the rationale. 50% of HIV-infected men have precancerous anal cells, even though most are symptom-free, which is huge. And women who are HIV positive have a higher degree of anal precancerous cells than cervical precancerous cells. And then finally, anal cancer clearly is easily treated if it's found early. So the idea is, how do we screen? Right now, if you have 50 docs in the room saying how they did it, there'd be 50 different ways that they were screened and treated. So the whole purpose of the anchor study is to standardize this nationally. So this is a National Cancer Institute study, by the way, and I think it's a really important study. So, and I'm sure you've got some things to say about it as well. So before going further, I'm just going to, the next, Ann Stapleton is our NIH researcher who comes from the University of Washington. She's a professor of medicine and infectious diseases.
I am.
I need glasses too. So this one?
Yeah.
And that to the back?
Yep.
There we go. Okay. So I'm going to talk about a little bit about my academic background and things that we are doing in concert with that, and things that we have been doing and things we hope to do for the future. So briefly, just to mention 2 trials. These are industry trials that we've been involved with. Both are actually now closed, but these are urinary tract infection trials of new drugs in women with urinary tract infections. And these are highlighting some of the work I've done and that intersects also with our HIV and just anyone who has sex population studies we hope to have going soon that relate to new drugs that address the big problem of antimicrobial resistance that's rife in the United States and around the world. So briefly just mention this. I've been NIH funded for about almost 25 years now, continuously, and I'm still involved in this consortium, which is prevention of lower urinary tract symptoms in women. And through this, right now we're in a sort of a think tank phase, and there's really nothing relevant to on-the-ground research with participants at this time, particularly not in men, but I do learn a lot about urological issues in men, and so it's been a very valuable involvement for me in my clinical practice as well. So the new trials that we have on the horizon at Eisenhower would include some pharmaceutical-sponsored ones and as well as some investigator-sponsored trials we're thinking about starting. So we have a major pharmaceutical company with whom we still have a confidentiality agreement, so I can't say who it is, but they have a new antimicrobial for highly resistant bacteria, and we are in the running for 2 trials, one in gonorrhea and one in urinary tract infection, and we've applied to be a site for both of these. Then in terms of investigator-initiated, I'd like to tell you more about our thoughts in this regard because NIH and PCORI and really everyone should be thinking about, can we do this trial because is the community interested in it? What is the level of interest and what is the level of engagement it would be? Because there's no point in doing any of this. And for this we would have to go out and get the money. So GSK makes a vaccine which was used in New Zealand, I'll tell you in the next slide, and found to actually work to protect against gonorrhea. So what kind of a problem do we have here? Well, this shows, I don't know how well you can see it, I guess you can see it fairly well. In Riverside County, these are from a presentation they gave about last year, 12 months ago, showing just over the a 5-year preceding period that the rates of gonorrhea are going up quite a bit. And I think that if you look at the slides more deeply, I didn't want to take the time today, most of it's in Palm Springs. And if you look at ethnicity, it's heavily among men who have sex with men. So what would we do? Why would we do this trial and what would we do? So there is no vaccine for gonorrhea, and the natural infection doesn't provide any protective antibody. The bacteria is very good at evading the host defenses by pretending to be the host when it enters you and changing its code all the time. So it's also known that Neisseria meningitis, or the cause of meningitis, the most common cause, and gonorrhea are very closely related bacteria. There are 2 vaccines for the meningitis. One is for serogroups A, C, Y, and W, and that's the one that most of you should have at least been offered, and most of you probably already have that. It's a standard in the United States. It's given to kids in early pre-adolescence and usually again when they go to college, and it should be offered to MSN, or men who have sex with men. Then there's serogroup B vaccine, Bexsero from GSK, which has been used in outbreaks in the United States, such as at Princeton, University of Barbara, and Oregon. You may have read about in the papers the last several years. So in this New Zealand study, they were receiving the serogroup B vaccine, an early one, that was similar to the Neisseria vaccine currently available from GSK. And the likelihood of getting gonorrhea in the cohorts that received this vaccine dropped a lot over when they looked back in a case control study, and the estimated efficacy of this vaccine was 31%. So the idea would be, if we did this in the Coachella Valley, what would we do? Well, it takes a lot of people. They had almost 15,000 people in the New Zealand study, and you have to look over a fairly long period of time. But in a different study, the actual antibody that protects you has been determined what it is. It's not that hard to figure it out with a good research partner. And in addition, it is more protective in the currently commercially available vaccine than in the one that was used in New Zealand. It has a couple more elements to it that provide better protection. So we would want to do a study that included as many sites as possible. We'd have to have the cooperation, and we would want to design the study so that there would be maximal benefit to the community, such as you got the vaccine or not, but after the study was over and we determined if you developed antibodies, you would be offered the vaccine if you would turned out to have been a control person. So if you were interested, you could get protection from gonorrhea. So I would like to ask, by maybe a show of hands, does this sound like something you remotely be interested in? You don't have to be positive. You don't even have to be a man who has sex with men. You could be anybody. So maybe about a third of people. And if we can, at the break, if you'd like, I can tell you what I know about the vaccine. I actually gave it to my own child because he was going to school near Santa Barbara, and there were some kids who got it. And I'm an informal consultant to the parent group at Cal Poly San Luis Obispo about this thing because it keeps coming up. It's hyper-endemic in Oregon right now among these young people, the meningitis side of it. And I have some GSK contacts. I know a little bit more about it. So thank you very much for your attention, and be sure to ask me any questions at the break if you like. Thank you.
All right. It's been exciting so far, hasn't it? So everyone's thinking, who's the new guy? You know, I've never seen him before. And, you know, I've met some of you. I've tried to, you know, reach out and talk to everyone. So my name, let's see here. There we go. So I'm Greg. I'm the research coordinator at DAP. Started a few weeks ago. But I did clinical trials for about 12 years, mostly on oncology, but some in HIV as well, in a past life. So now I'm on to my new life. You know, I'm at DAP and I'm loving it. It's very exciting there. So, I'm going to tell you just a little bit about, you know, again, being the new guy, just kind of going through. Here's kind of our research team, and some of these names you may know. Some of them, you know, maybe new to you. So there's Dr. Morris, our chief medical officer, and one of our investigators, Dr. Singh, who you may have gone to her wellness, talk this morning or this afternoon. She's also an investigator with us, sub-investigators, you know, PIs, things like that. These are all terms you kind of hear when you get into clinical trials. For the anchor trial, which Dr. L had talked about, and I'm going to give a little different spin on it. We have two endoscopists. They're our researchers. They're very important in this study. So their names need to be up here because this is, right, John, that, endoscopists are very, very important people. And then there's Hector and myself in the research department itself. So I just kind of wanted to throw our names out there in case you do come across us and you just kind of want to know what's going on. All right, so over the past few weeks, I've been trying to kind of wrap my head around the patients that we see at DAP and kind of where we want to go. I've been talking to Dr. Morris, I've been talking to Dr. Singh of what we want to do and where we want to go. So obviously HIV treatments, HIV-related conditions, and I'll talk about a study as well. You know, anything from anal dysplasia to AIDS malignancies to behavioral health conditions, and then also all the infectious diseases. So that's kind of what we see at DAP, and we would like to, our goal is to treat our patients the best way we can, and clinical trials does that. So many of you may have heard of the Chopra Study. So Deepak Chopra, we have an agreement with him through our facility, and so we're going to be participating very soon in this study, which randomizes patients to one of 3 groups. So these patients, HIV patients with mild to moderate depression, so obviously it's something that happens, mild to moderate depression. So then they are randomized to one of 3 groups. Either no treatment at all, just kind of do what you normally do to kind of get through the day, anything like that. Group 2 is then going to come to our facility and go through yoga, hatha yoga that we provide 2 days a week. And then also they're going to be going through some meditative processes. So, again, working on their mindfulness, and then taking a ashwagandha herb, which has anyone heard of the ashwagandha? I'm still stumbling over the words. So a bunch of you have. So it's kind of an anti-stress type herbal supplement. That's, it's been around for a long time. And so those 3 things will be used to see how it affects just the mental health of subject with HIV. And finally, the last group is just the same thing, but without the herb. So just kind of to see, because we need to compare all 3 subsets to really do a direct comparison of the patients. Right? Makes sense. All right. So now on to anchor. So we all know what HPV is, right? Yeah? Yes.
So the Chopra Study is not only about mild to moderate depression improvement with interventions, but also we're going to be looking at the inflammatory markers as well as T-cell counts and HIV viral loads improvement, absolute neutrophil counts, and CRP, interleukin 6, and TNF-alpha levels with the interventions.
Thank you. So the anchor study, which Dr. L had talked about, so we are collaborating together. If you see the numbers, it's a huge study. Looking at HIV patients, anal dysplasia. So this is kind of an anal cancer prevention study. It's not an HIV study, but we're targeting HIV patients because HIV patients are ones who are at higher risk for anal dysplasia and ultimately anal cancers. So over 5,000 patients, that's massive. It's been ongoing for about 4 years now, and we're just over the halfway point. We're at about 2,600 patients or so enrolled under the trial. So we have to screen 17,000 is the estimated numbers of patients to get that 5,000 on study. So it's a lot of screenings. Like I went to a facility just this past week in Chicago, and yeah, their screen failure rate is pretty high, but it's just a necessity of a trial that's built like this. So Dr. L kind of talked about kind of the science behind it. I'm going to just kind of show you a slide that shows kind of the details of it. So we're screening HIV patients over 35, which we talked about, for HSIP. So for those, if you know anal dysplasia or not, and so HPV affects those cells where there's that transition period between where the outside skin meets the inside skin. And there's several places for that. So your mouth, penis, cervix, and anus. So we take a scope, we take a look at that area to see if there's any sort of high-grade precancerous lesions in that area. Like Dr. L had mentioned, we don't know what to do with these things. Everyone's doing something. Is it best to treat them? That's what this study is going to find out. So if these high-grade lesions are seen, then you will be enrolled into the trial and randomized to either active monitoring, which means we're going to follow you very carefully. And when I work in the cancer business, people love being on clinical trials because you get awesome care. Not saying that, the doctors don't give great care otherwise, but this is a little more. So you're either active monitoring, where you come in every 6 months, we kind of take a look, or you're into treatment, where there's machines that we have to basically burn the lesions off, if that's what the endoscopist thinks that's the best choice for you, or there's some creams that we can use for more diffuse areas and things like that, to remove the high-grade lesions, and then again, keep repeating that every 6 months. All right, so that's kind of the anchor study in a nutshell. So finally, and I kind of touched on this before already, we're looking at DAP, we're looking at some treatment trials. There's a couple studies that we're looking through V Pharmaceuticals and Inovio Pharmaceuticals that looking at the best ways. Again, we want what's best for our patients. And so we all believe that DAP, and everyone up on this stage believes that clinical trials is that choice. All right, thank you.
You don't have slides, you can just sit there. Oh, you do have slides, okay, then step. I'm the one that has. Okay.
Hi everybody, I'm Shayna. I'm from Palm Tree Clinical Research. We are a standalone, solely research clinical site that's been providing clinical trials to the Coachella Valley since 2010.
Hey, Shane.
Maybe I might have slides. All right, well, I can go ahead and start. I'm just going to go ahead and start. So basically, I'm the head of infectious disease research as well as general medicine research at Palm Tree. And I'm just going to go briefly over some of my goals for my research clinic and what we have to provide to you as a community. So the first section of the research unit is simplification of your regimen. So we have a couple different trials for you that if you're currently undetectable and your CD4 count is greater than 350, you could possibly be enrolled into a clinical trial that can simplify your regimen for, decreasing your pill load or the frequency that you take them. So the first clinical trial that we have is called Pro-140. It's a monotherapy trial, so if you qualify and have a specific virus, you can take this medication called Pro-140. It's administered as a once-a-week subcutaneous injection, which means that you get an injection in your abdomen just under your skin once a week for 48 weeks. We do blood draws every other week to monitor your viral load and CD4 count. And then after that 48 weeks, if you are continuing to do well, we have an extension trials where you can actually continue taking the therapy until you want to stop taking that therapy or it stops working for you. I also have another clinical trial that is brand new. It's a phase 2 trial, so it's brand new. They're looking for 30 patients in each part, and there's 3 parts. So what those products are is called albuterol, which is coming from China. It was just recently approved last year in March in China. And they're pairing it with a monoclonal antibody called 3BNC117. It's administered intravenously over an hour, and they're testing a dose ranging. So right now they're looking at a different dosages of albuterol every 4 weeks. And the first part was doing the frequency, so they were looking at the dosages for every 2 weeks versus every 4 weeks. And then They take a break, do a data monitoring, and then they pick the optimal dose. So the third part is looking at the optimal dosage and comparing it against current regimens. So that one, those are simplifications for you. I also have trials that are for patients that are replicating. So,
You got your slides.
So that's enrollment therapy. The dosages, right now what they're looking at is a 700 milligram dosage, so I forgot to tell you about that one. The albuterol, the 3-part study, like I said, they're only looking for about 30 patients in each part, so enrollment does go quickly. So if you're interested in this, please come talk to us at our booth outside.
Who would qualify?
Patients that are undetectable, that have been on their current regimen for at least 6 months and have a CD4 count over 350. So these two drugs, it doesn't matter what tropism you have. So if you're pretty healthy and you're undetectable, we could look at you to enroll. So for those that are currently replicating, I have a clinical trial where we use Pro 140 plus an OBT, which is an optimized background therapy. So we run resistance testing on you when we screen you to make sure that we find the best drugs that can keep you undetectable with Pro 140. It's once again a once a week subcutaneous injection for 25 weeks. At a 350 milligram dose. After the 25 weeks, if you continue to do well, we have an extension study to where you can continue taking that regimen until it stops working for you or you want to withdraw from the trial. And then upcoming trials, these are in our pipeline right now. We have a HIV-1 vaccine for high-risk patients. We also have a trial coming up for patients that have gone off of the regimen and want to reinitiate their therapy. And I have another quick study for just blood sample collection that for HIV-1 positive patients, you just come in, take a blood sample, and of course you get compensated for your participation. So if you see any of these people around, these are my infectious disease research team. So we have Carlos Martinez, Alex Montoya, and Isidra Arredondo. We have been, like I said, we have been serving the community since 2010, 2011 with over 20 HIV clinical trials from that time to now. We also have different other indications that we're looking at that you can also be included for. So we have pulmonology unit, we have gastroenterology unit, we have a dermatology unit, and of course the general medicine that we just started up. So if you're interested or want to see what we're doing, we do have a website. You can find us on Facebook, or you can come in and talk to us. Okay.
Elaine was due to call us apology because she did send her slides, and I had to go to my email and look them up, so my bad for doing that. So you're going to go up there. Okay.
Why, hello everyone. My name is Tony Dorsey, and I am black and white and red all over. So, how many of you have seen me around? Anybody? A few of you? Okay. For those of you who don't, I work for Borrego Health. I have the unwieldy title of Strategic Program Development Specialist, which doesn't explain what I do. And what I do is I address the issues of trans people within the medical systems and social service systems within the region. So, although my iPad is sitting here on a 10% battery remaining morning, I'm going to go ahead and instead of showing slides, I'm going to talk to you about something that I want you to think about while you're working on studies, while you're considering different efforts that you're doing, because it's really kind of key. And part of this is because something recently came to our attention earlier this year, or sorry, late last year. Brown University's IRB approved a study on trans people, and that study actually did not follow ethical guidelines for studying trans people, which kind of makes you wonder, why did the IRB approve this, since that's their job? And the simple reason is that IRBs, by and large, do not have the cultural competence to be able to provide ethical decision-making when it comes to trans patients.
What's an IRB?
An IRB is an independent research board. They are the groups that have to approve your research, predominantly whenever you're doing any human subject research. They're actually designated an IRB officially and formally by the government. So they have to follow all kinds of cool rules and stuff. One of the things I'm infamous for doing is approaching researchers on HIV and our related populations, and I tend to ask them simple questions like, let me see my things here. So who here has done work with trans people living with HIV, specifically trans men and non-binary people? I see one, I see two, I see three. How many of you are doing research in HIV? So how many of you include trans men in your MSM populations? I know we do. You can just stop. How many of them would include, the reason I ask that question is almost everybody includes trans women in their MSM populations, and then what's the one thing we always hear when you're dealing with trans women in these studies? You can't find any trans women. They don't want to sit there and work on it. We're not men. If you tell me you want me to engage in an activity with MSM, I'm going to laugh at you because I'm going to wonder, what the heck's wrong with you? Why do you want a woman in a study where you're talking about men dealing with men? There's a disconnect there, and that disconnect is actually on both of our parts. On my part, because I'm a woman looking at this, and the disconnect on everybody else's is because they see trans women as men. And directly related to that is they see trans men as women. And that's not the case at all. The other question I'm infamous for asking is, how many people know the current risk level for gay and bi trans men or NB folks centered around STIs and STDs, and in particular HIV? Anybody? Yeah, that's the usual answer right there that I get. Because people say, well, we put trans men in our studies, but nobody's actually studied trans men, so nobody has a baseline to go from. And because trans men can be gay and bi, they are exactly the same population level risk as anybody else, except guess what? They're actually higher, because nobody's studying them, and nobody knows how to reach out to them to make sure that they're included and that they know. Most trans men, if you go up to them and start talking to them about the risks for HIV and transmission and stuff that we all take for granted, that we've all survived through, they will actually look at you with glazed eyes and go, I have no idea what you're talking about. Nobody has ever talked to me about these things. So imagine an entire population of people who don't know how to do that, deal with this. Trans women know more than trans men. And we really don't want to be talked about like we're guys, so that makes it even more complicated. And this is an institutional and personal bias that we have to deal with, because people consistently tend to think of us that way. And that's barely just touching on trans men. Although I mentioned non-binary, how do we account for non-binary people when all of our research functions on a binary basis? All of our research, everything we've got says men and women, right? This is the challenge that trans people bring to doing any kind of research. One of the things that I do consistently is I try to help everybody figure out how they can adapt their current data sets and particular research profiles in order to incorporate trans people so that we get a stronger data value set. I'm a sociologist, so I just love numbers. It's a weird thing, I will stare at a number chart all day long and go, oh look, there's a gap we have, and there's a gap we have, and there's a hole we have, and there's a nice little trend line that we can follow. Where do these things lead? That's my habit. And it's coming in really handy. How many of you are familiar with the work that Dr. Scheibel is doing at Borrego relating to methamphetamine use and HIV status? He would be here talking to you today, except he couldn't make it, and so you got me extra time. I just want to point out, though, that I've been kind of following that study myself, and you should see something within the next 6 weeks that he wants to get out to everybody. So kind of keep your eyes open. He's got something coming up there. So trans folks living with HIV face some interesting challenges, especially when it comes to aging. Not the least of which is the fact that they may be just coming out as trans now. They may have been a long-term survivor who suddenly realizes in their 60s that they're trans, or in their 70s that they're trans, or in their 80s that they're trans. I don't know too many people who've come out in their 90s, but the ones that I do, all are some of the most interesting people you ever experience having known, because they've all been through this, and they were already old when this whole thing started at that point, by our general standards. So among the things that they have to deal with is the fight for simple, basic daily courtesy and understanding in their daily lives. Almost all of our social service agencies and efforts are built around gay men. And trans women aren't necessarily comfortable in those situations. Trans men wouldn't necessarily mind. But the problem is that they aren't trans competent services either. So we're losing out on being able to provide those services. And it's not just in this area of living with HIV, it's across the board. I have my son. My son, if he decides he can't make it down here, or his life or his work does something, and let's say I get a little older and my little issues kind of encroach on me and stop me from being able to work, and I need to go into a home or whatever else, I'm going to have to fight just for the basic, simple dignity of being able to put on clothing that I'm comfortable in, of being referred to as in a humane way, in a way that understands it. And this is at any sort of senior living facility that we might have. This is not uncommon. This is a norm that this kind of hardship is what we're going to be dealing with. Now, it isn't universal, these challenges that many people living with HIV who are older deal with, but they often do not include that level of complete isolation, fundamental absence of any social services that speak to their specific needs, consistent social violence, and persistent social neglect of their most basic needs, such as a place to live, food to eat, and clothing to wear. If this sounds like the way things were for a lot of our population in the 80s and 90s and even early aughts, that's exactly where we are when it comes to the trans population. Our level of scientific knowledge and medical knowledge is a little bit higher than it was for our populations living in that early age of the massive expansion of the disease, but there's not much more than that. Nobody knows how to effectively treat it. When we did the study recently, or last year, they released the impact of the study with Truvada that showed that, you know what, guess what, trans women's exogenous hormones do not affect the impact of PrEP, right? PrEP is good, but that doesn't do that. The problem is that the hormones affected the PrEP, not the PrEP affected the hormones. Now, it wasn't statistically significant, but at the same time, nobody ever bothered to take a look at how trans men are affected by it, or where that level hits within cis women. So these are additional trend lines that we need to look at, because that's going to create the context for that original finding that we just mentioned. Now, that finding was really important for trans women, because now we can answer that question. And when it comes to trans people, always remember that they do not trust any kind of research group. There is zero trust. If they're participating, they're actually involved because they want to learn for our community, but they don't trust us. They don't even trust me if I'm in that research thing. And I'm a trans woman, in case nobody forgot that. So it's really important that as you go through that, you understand that that lack of trust is there, because that's going to actually have an impact on a lot of your findings. It's going to make it more difficult to get social data. That's important. How many people collect social determinants when you're doing your research? You better. How How many people know what social determinants are? A few? So demographics, basically, we like to look at that, but it's also looking at what is your current housing status? How stable is your housing status? All of these things to that effect. All of these little details matter for all of our populations, and we are only now starting to see just how that has an impact on the overall health and well-being of our populations. The social determinants for trans people are significantly, measurably, statistically, importantly, far worse than our general population of cis people. Who knows what a cisgender person or a cis person is? I just want to make sure. Anybody not know? Okay, a cis person or a cisgender person is people who are not transgender or people who are not intersex. In other words, the vast, overwhelming majority of human beings on the planet. Does that help answer the question for those who do not know what it is? In other words, we might call them normal, except that if you call me abnormal, I'm going to have some discussions with you back out there. So trans people have been here the entire time from the beginning of this whole process. We've been part of the communities, we've been there, and we've been involved in every effort that we've engaged in. And even though we've been often neglected, not because people intended to neglect us, but because, again, people don't understand that. We don't understand it as a whole. I'm including myself in that we. We kept coming back every single time. Cecilia Chung has been at the forefront of research related to trans people and HIV since the 70s, really. And she's still in that fight. And she's been knocked down, and she's been kicked out, and she's been pushed around, and she's still moving around. And I'm really proud to be able to say Cecilia is one of my best friends. Now, none of this is because no one wanted to exclude us, or ignore us, or skip over us. Our institutional and personal underlying biases tend to make us do things that link trans women to MSM populations, when doing such is basically a good way to drive trans women and trans men away. Among my ongoing efforts is linking the ongoing need of our research and examinations to ensure that our research escapes the historic gender biases and the even deeper biases on the physiological basis between cisgender and transgender populations. So if you need assistance in your survey, in your thing, I don't need any kind of thing. I'm not I no longer do academia and publishing or perishing, okay? I'll perish, I'm done there. That's just not my style. But if your research wants to make reasonable and understanding decisions about the inclusion of trans people, that's what I'm here for. That's what I want to make sure that everybody has the opportunity to understand. And to the best of my ability, I can hook you up to things, including the single largest HIV group of trans people in North America. I can't remember. Cohort, blah, my brain is fried. We actually have a trans cohort specifically, and I have access to it for those of you who also don't know, Cecilia Chung. And we can get the data and we can get their participation in things. So that's what I've got for y'all. Thank you very much.
Thank you all. This is terrific to get an idea of the scope of research that we have happening here, right here in our little valley. We've got time for maybe a couple of questions. Any burning questions people would like to ask? Could you shout?
Yeah, I have a question for Dr. Dorsey. Can you tell us more about what happened at Brown University?
I certainly can. So, how many are familiar with the challenges treating trans youth right now? Basically, okay, a few of you. The challenges treating trans youth right now is that there's a concerted ongoing effort on the part of a group of people who are colloquially known as TERFs to make sure that trans youth are not treated, and in particular, what they call young girls who are being misled into the act of transitioning into men. In other words, they're going after trans youth who are men on the transmasculine side. A particular researcher named Lisa Littman, who is an associate professor with Brown University, submitted a study to Brown University's IRB and was approved, and then published said study after she completed it in PLOS 1. The study itself is a study on trans youth and the basic communicability of being trans, focusing on teenagers. The methodology that she used did not involve talking to the kids at all. At no point did she discuss the actual subjects and the people about whom she made conclusions in the study. Instead, she talked to their parents. Now, the parents that she talked to were all members of the same sites she herself is a member of, and all of these sites are explicitly anti-trans. I'm named on 2 of them multiple times as being one of the most hostile human beings on the face of the earth to human bodies. So it's basically a hate group, checking in with other hate group people in order to say that their children are communicating and only became trans because they talked to other trans people at school, and therefore it's not happening. And they called this particular thing rapid onset gender dysphoria. And I mean, the bare definition of gender dysphoria means it can't be rapid onset, but that's what they're calling it, and they're trying to push this through, and it's become picked up by the religious right in the last few months, so it's really passing around. Does that help with the question?
Yes, thank you.
All I can say is, wow. Yeah, another question? Well, had to be our last question.
I'm Jonathan. Do any of the research studies that you've talked about today have an upper age limit?
Who wants
No. The quick answer is no. They do not.
No. None of that.
Normally it's based on employment status and things like that.
So,
As long as you're reasonable.
I don't want to put you on the spot with Desiree's project. You may not know the answer to this question, but because you're new, you're the new guy, right?
The new guy.
What's the population of people at the clinic who are over 50 years old? Do you know that? And if you know the answer, it's probably a high number relative to the population. Why isn't there any specific aging-related research at DAP?
Do you know the number, Dr. Singh?
Yeah, over 50%. And we collaborate with Victoria, and I am part of the stakeholders, steering committee and focus groups, and yes, we do participate in HIV and aging research. We have Victoria in our PS.
But the Victoria stuff, right?
Yeah.
Yeah, and also, a number of years ago, before Dr. Singh got here, that's why she doesn't know about it, UCSD did a pilot study on HIV and aging, started it at DAP. So there's a history there going back, I think about 6 years now. And they came to me and said, we want to study who do we talk to. The DAP is the largest provider, and now they're collaborating with other groups in the valley, so it's very productive. Well, thank you all for sharing what you're doing and for doing what you do.